Good morning, everyone. Welcome to this second day of our workshop. I'm once again Pavel Balabanov. I'm the head of office here at the AMA for the office that deals with neurology, psychiatry, and ophthalmology. And a warm welcome from me and also on behalf of our executive director and our chief medical officer, who sadly is still not able to join us. I would like to set up the expectations and the outline for today. While yesterday we discussed in depth the framework challenges and opportunities, today we'll dive deeper into the more specific aspects of development, and we'll have two sessions dedicated respectively to the trial designs and to the safety aspects of how we can develop drugs with this intention of getting them to patient as soon as possible. We have again quite distinguished chairs and panelists to present those topics. And without further ado, I'd like to present the chair of our next session, who is the vice chair of the CHMP, Professor Bruno Sepolis, a professor of pharmacological sciences at the Faculty of Pharmacy at the University of Lisboa. Also, for the ones that were expecting to see him in person, unfortunately, due to the transport chaos at Schiphol, he had to return to Lisbon and will be attending and leading this discussion virtually. So I will be helping him from here, the position in the room. Professor Sepolis, the floor is yours to introduce the session and the speakers. Thank you.
Thank you very much, Pavel, and good morning, everyone. Apologies for not being there, but as Pavel just said, I too was a victim of Schiphol. Again, thank you for having me here, and I'm thankful on behalf of CHMP for the opportunity to further discuss the development of psychedelic drugs and their therapeutic potential for the treatment of psychiatric disorders. Yesterday we had a very interesting session or group of sessions, and today we will continue, as Pavel said, diving deeper into the aspects that for us, especially at the CHMP level, the PRAC level, and of course the scientific advice working party level, will help us work with the framework that we have at hand, and also potentially identify areas that we need further regulatory support. So the session today will focus on, again, the challenges of trial design for these psychedelic-assisted therapies. And for this purpose, we will start with a presentation from Geeti Knudsen on the identification of methodological issues and how to overcome them. Geeti Knudsen is a clinical professor and chief physician at the Department of Clinical Medicine, Neurology, Psychiatry, and Sensory Sciences at the Copenhagen University Hospital in Denmark. This presentation, of course, will be followed by a discussion that will include the participation also of panelists that I will introduce later on. And of course, this discussion will be also open to the audience. So without further ado, I give the floor to Geeti. Geeti, I'm very sorry for not being there, but again, the floor is entirely yours. Look forward to hearing you.
And on. So thank you, Bruno. I was sad not to have you here, but good morning, everyone. And the session of today, let me see if I can advance it. I can. So as mentioned by Pavel, we will be discussing the intricacies of designs of clinical trials and how to do this best, and this is an open discussion. I don't think I'm going to present you with any finished solutions, but this is entirely up to the panel and the audience to discuss what I'm presenting here afterwards. So, conflict of interest, a couple of things here, and let's see if I can. Doesn't seem to be so responsive. Here it is. So I will be talking about several of the issues that, as Marion mentioned yesterday, have been raised in the paper on treatment of depression. But I would like to emphasize also here that while we talk about depression most of the time, because that's where most of the data are, there is certainly a scope for using these psychedelics in other conditions. And we haven't talked too much about that. But first, a little bit about the nomenclature. It was briefly mentioned yesterday as well. When we talk about hallucinogens, it could be psychedelic-like, which would be something like ketamine, MDMA, which works through the serotonin transporter or deliriums and also neurogens. What I will be mostly referring to during my talk will be the serotonergic psychedelics, also termed the classical psychedelics. They all act through stimulating the serotonin 2A receptor. So we know the mode of action quite accurately. It's debated what's happening further on. But some of the classical psychedelics shown here are psilocin, the main metabolite of psilocybin, mescaline, LSD, and DMT. And they can be assessed for their target engagement by doing molecular neuroimaging. And here you can see the serotonin 2A receptor. So by using these tools, we are able to say what is the target engagement and what is the occupancy on this receptor site. And as also mentioned yesterday, talking about these different psychedelics also entails discussing how long do they last. So generally, we have compounds such as DMT and 5-MeO-DMT that cannot be taken orally, but their mode of action is, their duration of action is very brief. Psilocybin, when taken orally, lasts about 3 to 6 hours, and LSD is very long, lasting 8 to 10 hours. So these experiences obviously are very different for the persons who are ingesting these compounds. And that is also something that needs to be taken into account when it comes to what kind of assistance do we want to provide and how burdensome is it. I want to say that yesterday we heard from Australia that the drugs had been reclassified from class 9 to class 8. But you probably noted also, at least some of you in this room, that class 8 was also entailing a degree of dependency. This is not the case with these compounds. You are not becoming dependent on these drugs. Actually, if you ask a participant who has just undergone a psychedelic session and you ask, how was it? They're going to tell you, it was amazing, it was fantastic. Hopefully, most of them are going to say that. And then you say, would you like to come back next week and say thank you, but no thank you. It's a very laborsome procedure to go through these sessions. It's a lot of hard work, and people are exhausted afterwards. And often they also get a little bit of headache, tension headache from this. So this is one of the adverse events. Right. So let's get started with the blinding, placebo, and expectations. We already touched upon that multiple times yesterday, but let's go a little bit more into detail here. So with psychedelic doses, the patients and the investigators invariably know what drug that they're getting, active drug. And the placebo effects, which are very prevalent issue with mental disorders treatments, will be even harder to disclose. And patient expectation may mean that placebo experience is disappointing, something we call nocebo. As mentioned yesterday, this has been looked into, and we are not quite sure yet to what extent that is the case. David Knott mentioned the study where they compared escitalopram and psilocybin, and that didn't seem to be a clear disappointment effect when it came to the psilocybin. People tend to be very polarized when it comes to the psychedelics. Either they are scared of taking the drug, or they really, really want it because they think it's going to be helpful for them. So that is at least our experience. And that may also mean that there is a bias, of course, in who chooses to become a participant in these studies. So how can we potentially cope with this? And here are some suggested solutions that you can incorporate different doses of the active compound in the trial design. You can monitor the subjective intensity of the psychedelic experience. And you also should ask what is the patient's guess of dose and expectation. And then, of course, use of independent and blinded external raters is also going to be helpful. And there may be other solutions that I'm looking forward to hear more about if people have more suggestions for this. And I just want to give you a couple of examples of how the placebo effect have been have been coped with in the past. And here you could see the Compass Pathways trial, which was one of the largest trials in major depressive disorder. And what you can see here is that when patients are given a dose of 1 milligram, which is virtually not something you can feel at all, then the outcome of the treatment is similar to a 10 milligram dose. However, the 25 milligram dose clearly has a beneficial effect in this study. So this is one way of coping with placebo effects. Another example here is from Sabin. I don't know, this is not the right one. This was the one I wanted to show. This is from the Sabin trial design. And are taken from their website. And here you can see that what was done here was to give an active dose or a placebo dose in a double-blind manner, and then to repeat it 2 weeks later, where everyone got an active dose, which means that you can tell people that you will get an active dose eventually. If not the first time, then you're certain to get it on the next occasion. So these are a couple of trial designs where you can try to tease out the placebo effects. Another interesting aspect is the dosing and maintenance of effect. And it has been shown in several studies now. This is a rather small study, but it's one of the first studies where people looked into the characteristics of the psychedelic experience. And when it comes to things like experiencing unity, the spiritual experience, and blissful states, scoring high on these during the psychedelic experience, or rather asking the people right after the experience is over, is something that seems to be associated with a better clinical treatment outcome. And this has been repeatedly shown in different studies by now. So there seems to be something about the experience itself and how it evolves that is predictive, at least, for the treatment efficacy. So characterizing that would be quite good. And a question that has been raised also in the past, there were quite some concerns a while ago based on what people had been telling from their own experiences, that SSRIs were supposed to dampen the psychedelic effects. However, it does not seem that concomitant use of SSRIs in a negative way affects the treatment efficacy of psychedelics. And then, of course, it will be really interesting to see the long-term therapeutic effects, and they should be monitored. An important point here is also whether patients are allowed to continue or to be put on more classical antidepressants, and this has mostly been the case. So obviously, this is something one could consider to put them on SSRIs, for instance, to put patients on SSRIs afterwards for the major depressive disorders. And then, of course, the question is one dose enough? Initial reports suggested that this was a one-time dose and it would be enough, but that is perhaps not quite so certain anymore, and maybe you would need to repeat it, and most likely you would in some cases have to do so, and maybe even with a larger dose. And then that brings me to the last point, which is the need for individualized dosing. There are individual variability in drug metabolism, age, sex, or perhaps even personality. And and this just shows you an example of how the plasma concentrations of plasma psilocin can vary. These people were given different doses, obviously, but you can see that the time to peak and the duration of the peak experience can vary quite a lot. But the intensity of the subjective experience tend to be quite well associated with the plasma concentration of the drug. And when we looked at the 5-HT2A receptor occupancy, and when you block the 5-HT2A receptor by giving antagonists, you can completely block the psychedelic experience. But in this case, we tested the receptor occupancy at various concentrations of plasma psilocin in different healthy subjects. And you can see that there is this single-site model that applies to psilocybin for the 5-HT2A receptor occupancy. And if you look at scheme A, the figure A, you can also see that the occupancy is closely related to the intensity rating. So the subjective intensity is closely associated with receptor occupancy, meaning that you need to get above, say, at least 40-50% of occupancy in order to appreciate the psychedelic experience, and probably you need to go beyond 60% of occupancy in order to have a solid psychedelic experience. So going beyond approximately 7 in the intensity scale is what is going to give you a safe and good receptor occupancy. Now, moving on to safety and adverse events, there are some acute effects. So these compounds acting as agonists on the 5-HT2A receptor also lead to some vasoconstriction, which means that you can see transient elevated blood pressure and tachycardia. I think it's not much more than you would expect from, say, doing exercises or jumping into a cold lake or things like that. And it is transient, but of course something that needs to be observed. Something that we have seen also quite a lot is nausea and even vomiting, particularly with higher doses. Headaches are quite common, as I mentioned in the beginning. About 50% of all patients who get a psychedelic dose will experience headaches, but it is hard work and tension headache. It can be tension headache, it can be migraine. And also what we see quite often, particularly with high doses, is some anxiety. And the anxiety usually emerges at the time point where people start to feel the psychedelic experience set in. And here it's important to have some sitters that can calm down and say this is completely normal, this is expected. And if they are in a calm environment, it is rarely a major thing. And again, it is a question about doses. If you give very high doses, you will see some anxiety. And then, of course, what you often hear about is harm to self and others. You think you can fly, you jump out the window and you kill yourself, or at least harm yourself. This is happening, and that is exactly why it needs to be monitored by someone in the room who can take care of the person in question. It also puts some particular ethical issues onto this, that it's usually a good idea to have 2 people sitting with the person who is experiencing the psychedelics, and in order to make sure that everything is done in the right manner, but because there is an obvious potential for abuse here. Then what about the late effects? People occasionally report about flashbacks, meaning that you're re-experiencing some of the experiences you had during the psychedelic session. They are not necessarily bad flashbacks, but they can occur. You can also potentially have personality changes in the sense that people tend to become more mindful, more open when you ask them 3 months later. They will score slightly higher on some of these personality scores in the Big 5. You can also have people who have altered metaphysical beliefs, or, of course, the more dared one is the development of psychosis, which means that it puts a certain importance into screening people before they are undergoing the psychedelic experience. And then the question of suicidality, which is always hard to judge, particularly in a cohort of people with mental disorders, it can be hard to know whether the suicidality has any direct links to the psychedelics or whether this is independent. And then finally, as we also discussed yesterday, the setting and the psychological support and psychotherapy. And here you can raise the question, is it psilocybin-assisted psychotherapy, or is it psychotherapy-assisted psilocybin therapy, or is it psychologically supported psilocybin therapy? And this is obviously something that we can debate, and it should be debated. I think that we need more research within this area to clarify what exactly is needed, and perhaps a more simple setting or assistance would be good to begin with. And then there's a question about the setting. You see sometimes rooms that are equipped with Buddha statues and smoke and whatnot. But you can also have more clinical environments, like a hospital bed. And how much does it matter? And just to illustrate that it actually does matter, we have this study where we had people have a psychedelic experience while they were MR scanned. And this obviously is a quite stressful situation. It's noisy, and you are put in a tight environment, and you can't really see people and the sitters around you. And when we, during the acute experience, when we asked them after what were their scores on the mystical and positive mood and the spirituality and blissful state, then the people who were in a quiet room where they were sitting, listening to music, they were lying in a bed with some sitters holding hands. Obviously, it was a completely different experience. And maybe you remember I showed the slide first that it actually matters for the therapeutic outcome, how people score on these different items. And it also applies 12 weeks later when you ask them, think back on the experience. What do you think? How did it change your life? And people would then definitely say that the experience in the room was much more pleasant. Now, being in an MR scanner is perhaps a bit extreme, but it would be worthwhile to know a bit more about what is it we need. And currently we are doing a study to see what does the music matter, for instance? And one could look at other issues, questions. With that, I like to end here and thank the funders and my group back in Copenhagen.